This evening we've got Dr. Kris Rasiah with us. We're not sure that he's got a voice, but he's here in person. Dr. Rasiah is an honours graduate of University of Sydney in 1992. He completed his urological training and received his fellowship from the Royal Australian College of Surgeons in 2002. Dr. Rasiah entered full-time research and completed his PhD at the Garvan Institute in 2006 and continued his appointment as Head of Academic Urology of the Cancer Research Group of the Garvan. Dr. Rasiah undertook further training in 2004 and 5 with a clinical fellowship to the Uro-Oncology at Addenbrooke's Hospital in the University of Cambridge.
How do you know all of this? This is incredible.
Well, it's on the website. His specific areas of surgical interest are cancers of the urogenital tract, including prostate, renal and bladder cancers, and of course his interest in laparoscopic surgery. Dr. Rasiah is the recipient of a Cancer Institute of New South Wales Clinical Fellowship in 2007-9. His more recent work supervising Masters of Surgery candidates at the University of Sydney has been focused on the quality of life outcomes of men undergoing contemporary treatments for prostate cancer, and of course that's his topic tonight. His role as clinical leader prostate and urological cancer with the Northern Sydney and Central Coast Area Health is also associated with his research interest in the improvement of delivery of multidisciplinary care of patients with urological cancer. Kris's topic tonight is treatment options for prostate cancer, and clearly he's very well qualified to speak on that subject.
There's a lot to get through. This is a massive topic. You know, we're really talking about men at the beginning of their journey with localized prostate cancer and making some very tough, probably agonizing decisions from a point of view of a layperson who hasn't done a PhD and spent 4 years realizing he doesn't know very much at all. You know, so it's I completely empathize with the decision-making process. You know, we struggle sometimes, right? And that's exactly why multidisciplinary teams are so important. I'll come back to that. So let's jump in. I'm going to talk about the issues to consider during the decision-making process. We're going to talk about aids to decision-making. You're familiar with nomograms and risk stratification? Exactly. We're going to talk about the treatment options themselves, because that's really the meat of it, and it's complicated. And some future developments just for interest's sake, and certainly questions as we go there. Right. So, the treatment options, what are they? We should really talk about that straight up front, right? And the treatment options, as always, is to do nothing, watch, or active surveillance. Oh, it's losing it. Surgery. I'll have to use my little mouse here. External beam radiotherapy. Seed brachytherapy. The wires, high dose rate brachytherapy. And these modern treatments, HIFU or irreversible electroporation. How about that? Get your mother on that one. But these are very, very exciting. The nano knife. Ever heard about the nano knife? Yeah.
Gamma knife, is that the same thing?
The gamma knife's radiotherapy. Nano knife, I'll show you, is about electrical treatment. Yeah. But they're different forms of energy. So, before we go anywhere near these treatment options, the thing we want to talk about is the first question. Should we treat or not treat? It's almost counterintuitive. It almost sounds crazy to talk about not treating cancer, right? But prostate cancer is a very different animal. And if there's one thing I learned from 4 years of PhD study, it is that it's an incredible heterogeneous disease, right? There are people who will, as we know, live out their lives with prostate cancer. And we know that about 3,500 men a year die from prostate cancer in Australia. So it spans this enormous spectrum of clinical behavior. So the first questions, really, to get right to the nitty-gritty, is the prostate cancer life-threatening? So how are we going to judge this? And it is the eternal question. We're looking for molecular markers. There's billions spent on molecular markers, like a blood test, like PSA. which will tell us, is this cancer going to be life-threatening or not? And clearly we don't have that one yet, right? Because we are all struggling with whether to treat or not treat. The things we can look at, the things we do have, are PSA level, Gleason score, and the stage of spread, or the stage of the disease. All familiar with that? Other critical questions: how old is the individual, and do they have other illnesses which may shorten their lives or indeed make the treatment too risky? Are you going to take on a robotic radical prostatectomy when you have a ticker that won't handle the surgery? Of course not, right? The father of radical prostatectomy is really a man called Pat Walsh from a large center in the United States, and John Hopkins. And he once said to us at a meeting when we asked, how old is too old for radical prostatectomy? And he said, I will consider a radical prostatectomy in any man as long as he turns up to the preoperative consultation with his dad. Do you get my meaning? We're talking about someone who has longevity on his side before you want to be taking on such significant treatments with their own risks. 10 years is the magic number that we talk about. What treatments are available and the benefits versus the risks of each? It's pretty obvious, isn't it? If you live in Wagga and you don't have a robotic option without traveling, and you want to be treated near your family, then you'll have the option probably of an open radical prostatectomy. I'm not sure if anyone does laparoscopic there, if you want surgery. If you want radiotherapy, you're going to have to travel. So that's pretty obvious. And absolutely and definitely the individual patient's values and their experience of cancer. If you've had a close friend or a family member who's had a terrible passing from a cancer of any kind, you're probably going to lean towards treatment rather than observation because of that experience. And certainly different cultural groups view the different treatments in very different ways. And that's been my experience. I've worked all over Sydney, including in the southwest, and that's certainly been my experience. There's some evidence here. The European randomized study, this very famous study about prostate cancer screening, they gave a figure of 7 years, and they said that people with a life expectancy less than 7 years really may not benefit from early detection and treatment, and probably shouldn't be screened. Interesting, huh? So when we say we're not going to treat, we're talking about watchful waiting. That means treatment when people develop symptoms. So we're not talking about curative treatment. Are we doing okay? Yep. So there it is, watchful waiting. We love these catchphrases, right, in medicine. So watchful waiting is where patients choose to observe their disease and intervene, yeah, but with treatments such as hormone therapy if and when they develop symptoms such as pain. Makes sense, right? Watchful waiting. Because you've got to distinguish that from active surveillance. So, if we decide to treat, what are the factors we're going to use when we're deciding between the treatments? And this is something my registrars, my trainees struggle with, because when you put them under the glare of the examination spotlight, they just go to jelly and they go, oh, what do I say now, right? And it's such a complex thing. So imagine if these guys are struggling, my patients, when they have to make these decisions, how tough must it be, right? So I give them this mantra: tumor factors, prostate factors, patient factors, that's their preferences, and things like their health, and institutional factors. Nice simple way of thinking about it. So always start with the basics. The tumor factors, as I said, the stage. Now in the past we used to decide that with the magic finger. I think my finger's pretty magic, pick up all kinds of things. So that's called clinical stage. And you remember the T1, 2, 3, just for your benefit, T1 is where you can't feel anything, T2 you can feel it, T3 is you can feel it and you think it's probably outside of the prostate. Nice simple way of thinking about it. But nowadays we've got investigations as well, right? We've got the classic ones of the CT scan to look for lymph node spread. That's all it really looks for, and it's also handy to pick up anything else that may change your plans. For example, you do the CT scan and goodness me, we pick up something in the kidney or in the colon. Bone scan, looking for spread to the bones. And these tend to be negative or not pick up anything when the PSA is less than 10 and the Gleason score is 7 or less. So it's quite common when people have low PSA and low Gleason score, low to intermediate Gleason score, that they will just go ahead without a CT and a bone scan. But this one, this is exciting. Anyone here had an MRI? Yeah. This one is the one that's going to be potentially a game changer. The research is still not firm, but certainly the clinical experience is. It is to the extent that most of us now are using MRI in the post-biopsy setting to really help us plan the surgery, see how far this cancer may have spread outside of the prostate locally. For example, has it gotten into the nerves, making nerve sparing too risky? And what's really exciting is MRI in the pre-biopsy setting, so that you can make sure with your biopsy that you don't miss that area of high-grade cancer, and so you can really understand before you get in there where that cancer is going to be when you do your biopsy. Very, very handy.
All the talk that we see online coming from America is talking 3 Tesla and endorectal coil.
Endorectal coils
around
in Australia, we don't really use it. I've never seen it in Sydney.
Yep.
3 Tesla versus 1.5. It's a really interesting question. I always thought 3 Tesla was the way to go. My wonderful boss from Cambridge wrote a paper about 1.5 Tesla MRI being useless. But in Sydney, you'll find many of the expert centres, which are private, and I think also Spectrum in here, may use a 1.5 in that pre-biopsy setting where you're looking to find or localize some cancer to make sure you hit that with your biopsy. So, and they are adamant that the 1.5 is as good, if not better, because some of the 1.5 machines have better algorithms and computerized techniques for really making those lesions pop out.
That doesn't seem to be what they're saying in America, though. They're just saying 3T or forget it.
I know. It's very controversial. Yeah, you have to go with what the radiologists tell you because they're looking at it all the time. And that's certainly what I've heard. Yeah, no, absolutely. No, the 1.5, they're adamant. Yeah, they can get all the information they want. But it depends on the 1.5 machine. Yeah, it has to be a newer generation machine. The PSA level, naturally the higher the PSA, the more chance it is spread. And the Gleason score, you remember what the Gleason score is all about? It's the pattern you see in the cells. So the next thing is the prostate factors. This is actually quite important. The size and the symptoms from the prostate are really going to be very important in determining what type of treatment you can have, right? And the easiest example to point to is the fact that larger prostates with these more, thank you so much, with these larger prostates with these more severe obstructive symptoms, and something that often goes with obstruction is frequency and urgency, rushing to the toilet, or indeed men who have prostate pain from previous inflammation, they're going to be less suitable for the brachytherapy options. And the reason for that is that with brachytherapy, you remember that either the seeds go in or the needles go in, and they tend to get more prostate swelling. And if you get prostate swelling and the inability to pass your water, it's not like my poor mates who head off and have too many beers up in surfers and go into retention, where they can get a catheter in, come back, they can have a TURP. After radiotherapy, the TURP carries very high risks of incontinence and very high risks of other complications like bladder neck stricture, that means the neck of the prostate tightens up, or urethral strictures. So because of that, if we are thinking about radiotherapy options in men who have significant lower urinary tract symptoms, we'll often do a TURP, a mini TURP, whatever that is, hopefully minimal impact, prior to the radiotherapy, and it's usually about 6 to 12 weeks prior. And I'm pretty sure that the radiotherapists tell me the longer the better, so at least 12 weeks. They may have hormone therapy while they're waiting for that. Make sense?
Yep.
Yeah.
Hormone therapy shrinks the prostate?
To shrink it, number one, and importantly, to keep things static while we're waiting for them to have their radiotherapy. Yeah. All right. Institution factors is really quite straightforward. It basically depends on the local equipment, but importantly also the expertise. You know, if the robots just come to town in a particular town, you're probably not going to want to be that surgeon's first or second patient, you know what I mean? Many patients are, everyone has to start somewhere, but you want to be making sure that that person has done his training and that he's supervised by someone who is a recognized expert. I'm going to say a few controversial things off the record. I can see the camera on me. Yeah, clearly, even the brachytherapy is very operator dependent. You know, you put those needles in the wrong place, you are going to get those strictures. And perhaps the thing about brachytherapy is, of course, you can, if there are any areas which don't have enough of the radiotherapy from the brachy, you can boost it with external beam. But the complications, you can't get those back, right? A local experience, yes, obviously, and institutional as well as surgeon outcomes. You want to know that it's an institution that gets good results because the surgeon's only one member of the big team, right? The patient factors, I think, are the most important, right? Because with a lot of the research that's out there, there's no randomized trials. So whenever someone gives you a definitive answer, they're probably talking through their hat, right? Because really, until you have that randomized data, you cannot, even with randomized data, you can't give definitive answers, but you can't come close. So the patient factors really are very, very important. Clearly the health and other illnesses such as heart disease, obesity, you know, very obese men not only have significant risks for their surgery, but their life expectancies are also going to be shorter than most men. And because of that, they really have to question whether they want to take on treatments like surgery if they're potentially not going to make it out to 10 or 15 years. Continence, yeah, look, continence and its early return as a priority, it is for all of us, right? But there are some cultures where it's particularly unacceptable, some employments, you know, if you're a professional golfer or, you know, another kind of a profession where you just cannot leak, then clearly it's going to be a big deal. If you can't live without your golf, it's clearly a big deal. Sexual function is a priority. That's high up the list because that's the one where really there are differences in the treatments, right? Surgery in an older male is going to have significantly worse outcomes in a younger male, even if you spare those nerves, right? So that opens up that question. If you're an older male, 69, 70 and older, that radiotherapy option really opens up if sexual function is a priority. Make sense? Yeah. Personal, cultural, family experience of cancer, we've already mentioned that. And your personality. If you love robots, you're not going to walk away from the option of having one of those, are you? I mean, the whole word robot's so exciting, isn't it? Yeah, absolutely. Whenever I think of robots, I always think of Forbidden Planet. Do you remember that movie? No, I love those old movies. Robbie the Robot. Treatment costs, yeah, absolutely. Unfortunately, the robotic treatments aren't fully rebated by the various companies and the hospitals. So because of that, it comes at significant personal expense. There is one robot in New South Wales in the public system at an Nepean hospital. I don't know, I haven't heard, they've not mentioned it widely, the surgeons who work there. I'm really not sure what the wait times are, etc. If the wait times are prohibitive, then clearly it's not going to be a viable option for most men. And geography, we've talked about that. How are we going? Yeah, good. The nomograms, you're familiar with this? The nomograms are basically algorithms where you feed in the information, the parameters, PSA, clinical stage, you know, what we can feel, the Gleason score, and spits out a number. This one is the Memorial Sloan Kettering nomogram, and it's available from their website. You can plug your own numbers in. Based on that, they'll give you a variety of outcomes such as the 5-year freedom from cancer probability. They'll talk about the potential risk of positive lymph nodes, extraprostatic disease, etc., etc. There are mathematical algorithms. So they come with all of the weaknesses of that. But in many ways, they are very useful. I often refer to these to help patients understand, that they've got a higher stage, higher risk disease. There's more of a chance of it being outside of the prostate. Maybe a treatment that manages more of the tissue outside of the prostate, such as external beam radiotherapy, may be for them. You see what I mean? So it's a very useful tool in helping one make decisions and helping clinicians advise their patients. A little trick you can fall into is, because it actually spits out the disease-free probability with both radiotherapy and surgery, is to try and compare the two. And that's really not an accurate way of doing things, because the patient groups are very different, and particularly the radiotherapy doctors are very adamant that you really shouldn't do that, because you'll end up always, unfortunately, the radiotherapy tends to do worse, and it's not always the case. I find this one really useful, this Albertson life expectancy table. Have you seen this one? No. This one, I think, is very, very useful. 20-year outcomes following conservative management of clinically localized prostate cancer in a very fine journal. And unfortunately, there is some historical stuff here. These Gleason 2s and 5s are really not seen very often. I have seen some 5s on TURP chips, but really we're talking about 6, 7, and 8. And the other hassle with this is the age groups it looks at, 55 through to 74. We're living longer. Many patients over the age of 75 do want to know if they've got prostate cancer, and they do want treatment. We've got all kinds of important things to get done. Heaven knows we're going to be working till 70. Well, I am. Well, I am. I'm turning 50 soon, and I've got a 9-month-old daughter. I'm going to be working a long time. I want to know what's up here. But the way you look at this is it's actually very, very straightforward. If you have, say, a patient with a Gleason score of 7, it's a nice number, and he's young, he's very young, he's only 56, right? So he's in this column. We want to come down to the Gleason score 7. This dark area is his risk of dying from prostate cancer. And at 5 years, that's a very worrying risk of 40% of dying from prostate cancer.
Do you go along with that figure?
It's pretty low. It's pretty high. Very high. Am I reading it correctly? 5 years. No, I'm not reading it correctly. 20%. Parallax error. I beg your pardon. Take that back. 20%. But his risk of dying from other things is very low. But at the other end of the spectrum, you take a 70 to 74-year-old patient. At 5 years, he's got 20% again. But look at the risk of dying from other things. See what I mean? So it's a very useful tool in really understanding that as you get older, the risk of dying from other things increases. And it's a really important graphical way or visual way of recognizing that. Make sense? Yeah. I mentioned multidisciplinary teams in terms of helping you make decisions. There's certainly one here at the SAN, Royal North Shore Hospital. Most institutions have them now. It's a team approach. Are you familiar with MDTs? Yeah. Look, I have to say that they're so busy and so packed now that what we call the fairly straightforward decision-making processes are often not given as much time, right? So a young man with a Gleason 6 cancer is, according to evidence-based medicine, right? He is open for all options of treatment. Sure, we'll have some preferences, but it has to be an evidence-based decision or advice that they give. And so a young man with a Gleason 6 and a PSA of 5 is open for all options. Similarly, a patient who is a bit older, maybe 69, with a Gleason 7 cancer, and low PSA is open for all options. You see what I mean? So those patients tend not to get discussed anymore. However, if you as an individual patient think, look, I really feel like I'm getting pushed towards some treatment that I'm not interested in, this is one of the controversial things I'm going to say, right? For example, if you're 72 and robotic radical prostatectomy is the only treatment you've been offered, and you feel that there's something not quite right with that, I think you should be asking, can I please be discussed at an MDT and have that decision fed back to me? I think that's the modern way of cancer treatment. It's what we use in breast cancer, colorectal cancer, etc. And there's a team approach: urologists, radiotherapists, medical oncologists, pathologists. It's a very useful team meeting. There's a lot of communication, there's a lot of education goes on because I can communicate directly with those radiotherapists and medical oncologists. And it really opens up the full range of treatments to patients who are discussed at those meetings, including clinical trials. And really it should be regardless of geographical remoteness, because of course we have internet and case conferencing. And as I said here, it really has to be in accordance with national guidelines and international standards. In a little way, it's a kind of clinical governance. And when I was training in Cambridge, this had just come into the NHS. This was back in 2004. And really, it's a very big part of how we do things now at most of the big centres. Understand all about MDTs? Yeah. Oh, good. Yeah. So back to the treatment options then. Surgery, radiotherapy, active surveillance, HIFU. Let's talk about active surveillance. It kind of goes against everything that we know as surgeons, right? You find a cancer and you don't jump in and remove it, right? So the simple fact is the research is out there. It's got very high levels of safety, and there's a lot of not just evidence, but a feeling that, particularly when we talk about over-treatment of prostate cancer, that this is one of the ways that we can help to avoid that. So what is it? It's deferring curative treatment until there's evidence of actual tumor growth. The problem is that all of these aren't definitive, and if you're looking for certainty, you're probably not going to find it here, right? The PSA, well, it can go up because of the biopsy alone. And it is probably the least definitive way of looking for growth. However, when we talk about PSA increase, we usually talk about a doubling time greater than, that's a doubling time less than 3 years, right? So every 3 years that PSA can't be more than double. The digital rectal examination, again, sadly, not definitive. There have been a couple of times I've had patients where I've felt their prostates 6-12 months after the biopsy, and I feel a lump, and I hold my head and I think, oh dear, is this where we're going to get caught out? You do the biopsy and it's inflammation. Thank God. Repeat biopsy is the best way, and it's very difficult because the biopsies aren't fun and they carry their own complications, including some evidence out there that repeat biopsies can be associated with erectile dysfunction. It makes sense, doesn't it? The nerves getting scarred. So, oh yes, that's very controversial. So the problem, of course, is that repeat biopsy, the second biopsy, is the critical biopsy. And a lot of the research really points towards that. And it is mandatory. And many patients really balk at that. And a lot of the active surveillance studies are beset by the fact that many patients don't want to come back for that repeat biopsy. Yeah. Understandable. Particularly in the United States, where it's done mostly under local anesthetic.
Do you do local?
General anesthetic, goodness me. Oof. And we've struggled and fought to get the general anesthetic ones available at Royal North Shore in the public. Yeah. So in fact, the hospital very kindly suggested that we as urologists buy the machine. We thought, oh, gee, that makes sense. Yeah, thanks a lot.
Sorry if I may just interrupt. When it comes to repeat biopsies, how many is the sort of maximum? Is the second one about as far as you should go when it comes to being tested, or is it a matter of time?
The answer isn't out there. We don't have that answer. So the traditional was that it would be 1 year, 12 months, and then 2 to 3 years later for the third biopsy. But look at this thing. And the studies are being done now at the Garvan Institute, looking at, there's double question marks, the role of MRI in monitoring men on active surveillance. I'm already using it in my clinical practice. I'm a bit paranoid. So after that first biopsy, people often get an MRI 1 year later. But the problem with MRI, of course, is it's not rebated. And the way that they're talking up Mr. Abbott's speech coming up about the economy and taxes, I don't think it ever will be for prostate. It's a real problem. And it's not possible to get it in the public system either, as an outpatient. Close monitoring is required 3 to 6 monthly. You have to be willing to do that. And that by repeat biopsy. I put it in capitals. And the important thing here about over-treatment is that we know from that big screening study that 30% of patients are likely to be very good candidates for active surveillance. 30% of all patients. It's certainly not suitable for all personalities. You have to be able to live with untreated cancer. Yeah, that's a very tough thing. Your surgeon has to be okay with you living with untreated cancer because, of course, it's something that we're all thinking about. You know.
Kris,
David,
with people on active surveillance, do we know how many of them eventually have treatment?
I knew you'd ask the good questions. I'm coming to it. Because that is the question. Let me get to it very quickly. What criteria do we use? It's really pretty straightforward. It's for patients with, this is one of the criteria, no Gleason pattern 4 or 5, PSA density, that's the PSA divided by the volume of the prostate of 0.15. I have to say I don't use that very much. Fewer than 3 of the cores involved in a 12-core biopsy. A maximum involvement of that core length of 50%, and a Gleason sum, which goes with that, which is 6, right? So what we're talking about, it's hard to remember. Low grade, low stage cancer, low PSA, which can be easily monitored, so it's not 12, it's not going up and down all over the place, so it's impossible to try and monitor it. A motivated patient who's able to comply, and classically, an older patient is going to be more suitable. So, David asked the magic question. About 25% will go on to active treatment by 5 years in the biggest series from Toronto, from the Sunnybrook Centre, which is Professor Klotz, if you've ever heard that name. 25% at 5 years. The death rate, yeah, it's there, and I told you this is not perfect. 2% from prostate cancer at 10 years. But in that same update, which we got this year, 15% from other causes. This is presented just now, live off the net. Answer? That answers your question? By the way, just as a bit of reassurance, these 2% tended to be, in this study that Professor Klotz did, he did have some Gleason 7 patients. And when we met him at a conference, he said almost certainly the patients who did die were unrecognized 7s. That's why that second biopsy is so critical, so critical. Okay with active surveillance? Yeah. Question? Ask.
I think many of us will accept what you're telling us, but I think most of us are pleased we've had some treatment, which is another thing. Particularly people that had fairly low PSAs, low Gleasons and things like that. I think if the outcome is good and the side effects are minimal, people are very happy that they have had treatment.
Oh, I'm coming to that. because
sure.
there's some very recent data which is very worrying from the pivot trial. Oh, very good, very good. So, I mean, we have to be balanced, right? Because there is a lot of evidence that there was a lot of cancer that was treated that perhaps didn't need to be treated, right? But when you have that individual sitting in front of you, right, and that individual patient who has to make those decisions, you know, you're going to err on the side of caution, right? And that's simply the fact. So we'll jump straight back to the options, going down to surgery, all right? Very controversial, of course, but a lot of that controversy is going to melt away because I'll show you one of the papers, right? Radical prostatectomy is the removal of the prostate and the seminal vesicles. Just remembering the anatomy, this muscle here is the external sphincter and the issue of continence, right? The nerves aren't very well shown there. So, major surgery, right? Oh yes, robots are wonderful. This is major surgery. The surgical removal of the prostate can be laparoscopic, which is the keyhole surgery. Robot-assisted surgery. Notice I didn't call it robotic surgery. It is still laparoscopic surgery. It is the most common curative therapy we take on, in Australia at least, and it is for fit patients with clinically localized disease and a greater than 10-year life expectancy. Most of the guidelines will tell you that. And the big deal is these two, incontinence and impotence. So here's the all-important nerves. That's one on the right side intact. This left one has been taken. Here it is on the prostate specimen. So why was it taken? It's this issue of nerve-sparing surgery, right? It is a very important concept because it's all about maintenance of quality of life, right? And if you take those nerves, that potency rate is going to plummet, especially in an older patient. This is the surgery happening with the prostate being peeled back, the urethra there, and here's our nerves. This is bilateral nerve-sparing surgery. But what's the big deal? Why don't we spare it in all men? Especially because there is a fair bit of evidence now that leaving these guys intact can help with continence as well. And the reason is simply this, the tumor. This is a cross-section of the prostate. The rectum is down here. The prostate is here. The fascia of the prostate. Blood vessels going with the nerves, the little yellow guys. But look how close they are to the tumor. And you have some tumor outside of the prostate. You spare those nerves. We're talking about fractions of millimeters. Robotic magnification is magnificent, right? Is it that good? It's a risk, isn't it? The MRI is terrific in helping us with this, but it's not perfect. Oh yeah, it's not perfect. So this is the big decision, you know, whether one would try and nerve spare or not. Most surgeons will advise their patients to err on the side of caution, but it's an absolute choice that each individual will make depending on their own life circumstances and their own preferences, right? But they need to understand that they can have nerve-sparing surgery. Technically, it's something you have to learn. You really do. Questions? Abby? So radical prostatectomy had a pretty bad name in the early days, right? But really, since this time, these figures, they may be better by 1 or 2%, but these are fairly real. Let me just take you through them. A transfusion less than 10%, or certainly it's probably less than 2%. I don't think I've ever transfused a robotic radical prostatectomy. But there's still the open surgery, of course. Major complications, 2%, that's real. You know, things like rectal injury. Early reoperation is low. I haven't had one. Catheter, 7 days is about right. Yeah, most people do 7 days. Even the greatest, Pat Walsh, would leave it 10 days. Why? Because that happened to be his clinic day, so you could make sure he was there. That's the kind of thing we're talking about. It doesn't really affect anything. Length of stay, yeah, 2 days. It's easier to have a length of stay in 2 days in America when they chuck you out of hospital in 2 days. But in Australia, really, it is 2 to 7 days. 7 is really pushing it.
Could I ask you a question on that length of stay? I was reading an article today which was based on statistics, and of course the people were querying so many parameters of the report. But one of the things that they did say is it was an argument against open and robotic surgery. But in America, both of those, the average stay was less than 2 days. Any reasons, any comments?
Yeah, look, it depends on the individual centres, right? Often the patients go home with their drains. They often go to a hotel across the road and are looked after by nurses. Often they'll travel back to their own towns. So it's not necessarily this hotel story. They'll get in their car and they'll be travelling with a drain. And it's pretty heavy-duty stuff. And it must be okay because it's such a litigious society. You can't imagine people being chucked out of hospital, but really that's about it. Yeah, they just have, and often the individual centre will have protocols and things set up, like the nurses to visit the patients. Like plastic surgery patients often have a nurse visit from their doctor, but someone pays for that. Yeah. I mean, most of my patients stay about 3 to 4 days. Yeah. And for example, in Australia, I won't send my patients home till they've opened their bowels. And in America, you'll be going home even without a passing wind. Oh, definitely. Well, you just don't know what's going to happen, and I think it's cruel. And things like incontinence. Look, this figure is probably a bit unrealistic. I think severe incontinence is somewhere between 1% and 5% for all comers. Much less so in the younger men. Under 55, it'll be less than 1%. Yeah, sure. But how many of our patients are under 55? So certainly I think it'll be in the 1 to 5% group. Mild to moderate, less than 3 is not realistic. I'd say it's so if you're including the miles, it'll be, I think, 10 to 15%. You have to be very realistic. Incontinence is certainly an issue. The open surgery is still there for our public patients. The cut in the lower part of the tummy. Someone here was a patient of Henry's. He does a transverse cut.
Yeah, he does. He used to do up and down.
He used to do up and down. The laparoscopic surgery, I put this in, it's fairly historical now. Most of the laparoscopic surgeons have switched over to robotic, but it gives you the concept of an instrument passing in through a tiny hole. And the key with the robotic, I like this because it really tells you how the robot works. It's this machine that holds the laparoscopic instruments. It's still this guy with his head here. When my professor used to do this, one of the very unkind registrars used to say, "Oh, look, professor's got his head in an elephant's bottom." Very unkind, very unkind. What are the advantages? These are the proven advantages, although you'll hear all kinds of things from proponents of the procedure, but decreased blood loss is proven, decreased transfusion rate is proven, less pain is proven, decreased wound complications. Of course, you've got tiny little wounds, and better cosmesis. I don't know if anyone's modelling career is at risk, but a quicker return to normal activities. I put these in italics because I feel these are things that I've noticed. The big disadvantage, I haven't put in even the issue of cost here, but is the learning curve for the surgeon. So most of us who had extensive experience with open surgeries, I was about 200 or 300 opens, over 12 years, taking on a new procedure is something that doesn't come easily. Yeah. So that's what the setup is like. The machine, the assistant surgeon, the screen that the assistant looks at, anaesthetist up the top. And the instruments driven by these joysticks. Cancer clearance, what's the answer? It's pretty much the same, isn't it? Roughly equal. Continence, potency, roughly equal. Here's some stuff you wouldn't have seen. This is from one of our quality of life studies from the Garvan Institute. We're looking here It's a bit hard to read these, but it's my publication, so it's very important. Looking at low dose rate brachytherapy, seeds, versus the robot. Looking at continence, right? Following it down. That is the low dose rate brachytherapy. Look at the difference. It's these little hatches mark statistically significant improvement, and the low dose is definitely better. It makes sense, doesn't it? It makes sense. Robotic surgery versus open radical prostatectomy, millions of dollars, right? What do you notice here? Do you see any hatches down here after 12 months? No. Interesting, huh? Yeah, very interesting. But experience makes a difference, yeah, for the individual surgeon. Robots and sexual function. This is a very hard one to read because it's a weird graph. It's whatever's closest to the hatches is better, right? And for the first time we proved that low dose rate brachytherapy had better sexual outcomes going forward out to 2 years than robotic surgery. That's not been shown before. Robotic surgery versus open is better, but, and I wrote this paper, statistics is something you've got to look at very carefully. What you don't see when you see this graph is that many more of the robotic surgeons had nerve-sparing surgery. So of course they're going to be better, right? Now, we sit around when we write these papers and the authors all argued, yeah, but the robotic surgery makes it easier to nerve spare, and that's why that is better, and so we should leave that in. So we did. But if you're trying to compare apples with apples, I don't think if you're a public patient who's going to have nerve-sparing surgery in a public hospital and have open surgery, you should feel you're getting hard done by. No way. Yeah, with experience, the nerve sparing gets better. Yeah, definitely. Happy? Yes. So advantages again. Yeah. But this is what I really wanted to point out. So we cannot make our patients who don't have the access to the robotic surgery think that they're getting something inferior, because we haven't proven that, right? In fact, there was actually a paper from a very august journal, the JAMA, saying that they got worse outcomes. And you'll read a lot of stuff on the internet about that. Cost. Oh, he's going to sleep. That's it. I better keep going. Low dose rate brachytherapy, right? You want to hear about radiotherapy from a radiotherapist, not from me. But I'll just tell you that it's all about the seeds being placed in. It's convenient because it's a one-stop procedure versus external beam, which is 6 to 8 weeks. It's got very good outcomes with low-grade, low-stage disease. And so that's the only one that's rebated. That's low-stage Gleason 7s. That's low PSA, and all the Gleason 6s. High potency rates. I showed you the figures. So we were saying this before, but now we have the proof. Incontinence and severe rectal side effects are rare, 1% for the rectal side effects. Definitely not for all patients. We talked about the tumor and prostate factors, the size of the prostate, etc. Complications, seed migration, strictures, urinary retention I talked about, and bleeding. There's the seeds. Final outcome. If it set off the airport alarms. High dose rate, very similar, through the perineum. The needles are put in. This is a man with his legs up. There's the cannula, as they call them. And through that goes a tiny wire, which is highly radioactive. Goes in, it has a dwell time, stays in for a few minutes. Oh, no, take it back. A few seconds, and it comes out again. You may or may not need to have additional external beam radiotherapy with it. You may or may not need to have hormone therapy with it. And interestingly enough, it's the hormone therapy in these patients which gives them the worst quality of life impact. Yeah, it's a tough treatment. Any questions on this? This is the one where, because if it's a high dose coming very quickly, you can get into trouble with things like radiation strictures. Questions on this one? Yeah. External beam radiotherapy, and increasingly, I have to say that I've noticed, particularly the guys I work with, are steering away from low dose, from seeds, towards the more targeted forms of external beam, like IMRT. And they've got all kinds of names now. Rapid Arc is the one at the Mater. I think they do IMRT here. It's not invasive. It's a hassle. 7 to 8 weeks. Risks of bladder and bowel toxicity are definitely there, but again, it's in that 1 to 2% for the severe side effects. But, you know, I've got a few older guys who are on warfarin particularly, who have the radiation cystitis and difficult bleeding. It's a tough thing if you get it.
Could I ask a question on that one? How do you feel about external beam radiation for chaps that have had a radical prostatectomy and their PSA rises?
Oh, it's one of the selling points for radiotherapy in a younger man is that if their disease comes back, they have this option left. Whereas if you've had radiotherapy, the side effects of salvage prostatectomy, removal, are enormous. 50% incontinence rates. Rectal injury rates in some older series, 10 to 15%, because it's stuck, it's scarred, right? So that's one of the arguments that will be used in younger men, and most of us feel that because of that issue, the younger men generally should go for the surgical option. And most radiotherapists will also agree with that. Of course, there are some who will go according to the statistics and say, look, no, show me the proof. Right? Yeah, there's some very, very good targeting systems out there. Yeah. This is a gentleman lying on the table, having his radiotherapy. So what should I choose? That's the question that my patients ask me, and I know this is a toughie. This is a toughie, right? And my answer, I don't whip this up, but this is my answer. One size does not fit all, right? You can't say, you've got prostate cancer, you should have your prostate out. No way, right? I think there are some people who may do that. It has to be individualized, and individualized to all of those factors I talked about, right? You have to go through that list. Tumor factors, patient factors, etc. You have to. So, surgery versus radiotherapy study. I can see you smiling, you've seen this one. This from this gentleman who works in Oxford, I think. But he did this when he was working with a big Swedish group, a comparative effectiveness of radical prostatectomy and radiotherapy. You should see the comments on this if you ever get a chance. The vitriol, goodness me, you know, back and forth, radiotherapists versus surgeons. I think they'll do it for a game. It's an observational study, yeah, but it was prospectively collected data because, you know, the Swedish, there's one thing the Scandinavians are wonderful at, it's collecting data, right? And of course they do, they've got wonderful social security systems. Compared the mortality in over 34,000 men treated with radical prostatectomy. Median follow-up 5.4 years, which some have said is too short. But they've got patients who are out to 15 years in the study. And the prostate cancer related death adjusted for potential confounders, that's what that means, was higher amongst those patients treated with radiotherapy than with surgery. That's the answer, 1.8 times. So, of course, you're going to say, you know, what are the, surely there must be something wrong with that, right? More facts, right? This is just what happened. Subgroup analyses, even greater survival benefit for prostatectomy versus radiotherapy in younger men, 65 and less, and fitter with fewer comorbidities, because they're not going to die from the other things than men, and men with intermediate or high-risk cancer. Makes sense, doesn't it? It just makes sense. Compared to radiotherapy, surgery associated with roughly 1 to 4, depending on how you looked at the statistics, fewer deaths, but they're per 100 men. And the reason for that range is the high-risk men had a higher benefit than the low-risk men. Tough, huh? Is it an easy answer? No, of course not. Of course not. It can't be. The strength of the study is that it's got a big sample size. Lots of data was collected, but they didn't look at whether men got adjuvant radiotherapy after the radical prostatectomy, which was your question. You can have it. And that may confound the results. It's not randomized, right? And any statistician will tell you that, yeah, you can adjust, as they said, for things like frailty, age, worse disease. But really, there are aspects of that which statistics just can't account for. And it tends to be that the older, frailer patients with worse disease often went for radiotherapy. That's just a simple fact. Any questions? Because it still comes back to this. But that is an interesting study.
Recognising how complex the decision making is, even for the doctor, even more so for the patient. How do doctors feel about patients getting a second opinion?
Yeah, I think it's a pretty good idea. If it was me, I would. The problem is, who do you get the second opinion from, right? If you go and see a so-called prostate cancer expert, yeah, he'll know this data, etc., right? You've got to remember he makes his money from taking out prostates or treating people with brachytherapy or whatever, right? It's a very tough thing. I know this whole issue of how to get a second opinion. There are some surgeons, there used to be a guy called Jeff Hurst in Queensland, who was obviously a very intelligent man, who didn't do prostate cancer surgery. And he used to be the best guy in Australia to get an opinion from, because he would know the data, he had no vested interest, he would give you an honest opinion. But I think that multidisciplinary team meeting is an excellent way of getting that. But again, you have to be able to get exactly what they said at the multidisciplinary meeting fed back to the patients. That's something we struggle with. But yeah, a second opinion, it's a no-brainer. Yeah. If you feel that you haven't had everything you want from your surgeon, yeah.
Yes, how do you go about getting a team
opinion?
organised? Is it a matter of
you just ask, say, "Hi, Dr. So-and-so, you know, I went to this talk by Kris Rasiah and he said, I really should have a MDT discussion." He'll go, goose, you know, but he has to do it. The Cancer Institute mandated it a couple of years ago, you know, that everyone should be able to have the option of being discussed at a multidisciplinary team meeting. They get us lots of money for it. Yeah. I mean, the other way of getting a second opinion is in someone who has those choices, right? Can I see a radiotherapist? Can I ask him some questions about radiotherapy? And I've got a slide up at the end. You always have time to do that. You know, there's often this, you've got cancer, everything has to be done very quickly. There is always time. This thing has probably been growing for years. A couple of weeks will make no difference.
Kris, that last dot point, doesn't that sort of negate all the results pretty much? Because it seems that the better patients went for the surgery, and the older and...
You sound like the radiotherapist.
And worse patients.
No, it doesn't, because they did try to account for this, right? They did try to do the adjustments. But I'm saying to you, look at the data for what it is worth, right? But no, you can't say it negates it. No, you can't negate data. Data is there, right? And simply the men who had surgery did better. But the question you have to ask is why? Yeah. It's a great question. It's a great question. It has a lot to do with medical statistics, right? And that is the great issue. I showed you my own picture and I told you, look at that, right? The guys who had robotic prostatectomy had better potency outcomes than open surgery, right? But I told you the reason was that more of them had nerve-sparing surgery.
You mentioned subgroups in some of your earlier statistics. how far do you go down into getting subgroups? I mean, you can give statistics for all men that have been treated with all treatments for prostate cancer, or then you can come down to subgroups of socioeconomic groups, ethnic groups, age groups.
And you know that the more subgroups you form in your statistical analysis, the more you affect the data. It's fascinating.
Yeah.
And these are all the issues with medical statistics. So, look, with all of these things, like I said, it's very hard to get these definitive answers, but you have to look at these things for what they're worth, right? It's 34,000 men. This is how they did. We use that data in whatever way we can, right? The problem is people will use it to push whatever they want to push. And that's why I think it's so hard. It's so hard to make a decision, but this is what we have, right? Let me just take it for just a little bit further, and then I'll just take some more questions because it is such a complex area. So focal therapy, HIFU and nanoknife. HIFU is high intensity focused ultrasound. If you're very unkind, you'd say high income for urologists, because some of the costs of this therapy have been very, very high. Sadly, it is not mainstream therapy yet. And the reason for that is that the studies really aren't out to long enough. The risks of the surgery, of this procedure, haven't been fully controlled yet. Incontinence is still present, strictures are still present. There have been these fistulae, which is a disastrous complication. Retention and impotence was still very high in the early data. But it's not surgery, right? And it hasn't got the side effects of radiotherapy. But then you'd ask, well, if it's not surgery and you've got these side effects anyway, why wouldn't you have radiotherapy? Those are the questions that come out. It's not mainstream, but it is potentially a very important treatment that should be looked at because it may be there as salvage therapy for radiotherapy patients. And that's why, you know, I think it's important that there are, and I made fun of it, you can take that one out of the, edit that one out, but it certainly has a role. Here it is, the nanoknife, electroporation, again, very exciting. Application of electricity through these needles. So this is a picture of a liver metastasis, and these electrical tines are put around the lesion. So how are they put around the lesion? Well, you can use ultrasound guidance. You can use MRI guidance, which is probably even more accurate. And the electrical current that you pass between these leads to the formation of these tiny punctures or holes in the cell membrane, and that leads to the cancer cell dying. And they've done some trials, and there's a trial going on in Sydney, actually. You can see here there's a lesion. Ooh, I think I put my arrow right on it, just there. And you can see the little dark area. Here you can see there's a white area and then a punched out dark area, dead tumor. You know what I find most exciting about these pictures? That you can see the tumor on the MRI. That's what I find really exciting. But I have to say, this is potentially for the future. It actually brings out this whole idea of just treating the tumor and not the whole prostate, focal therapy. And that's a concept I think as urologists we're still going to struggle with, and radiotherapists. The molecular markers I talked about, AZGP1 is a trial which from our Garvan Institute, which we'll be reporting. The pivot trial I talked about observation. Just because you asked about it, I'll just take you straight through to that. I had a slide there at the end. From the New England Journal. And they found that men with localized prostate cancer are less likely to die from their disease if they undergo radical treatment instead of watchful waiting, especially if they're younger than 65. At 18 years of follow-up, radical prostatectomy associated with an overall significant 44% decreased risk of death from prostate cancer compared with watchful waiting. Kind of like that picture I showed you. And this is just reported in the New England Journal. Yeah. So summary, we talked about the issues in decision making, we talked about the aids, nomograms, multidisciplinary team meetings. There's your second opinion. The treatment options. And I keep harping on about this because I really think, for many men, particularly if they're feeling like this is all going too quickly and I'm heading towards a decision I'm not entirely comfortable with, this is a little strategy for a bailout, and even seeking a radiotherapy consultation or a urological second opinion is incredibly valid, because it's all about this, this person in the middle, right? Yeah.
Any questions? I'll ask one.
Mm-hmm.
I think, and I could be wrong here, that they're determining in breast cancer there are many types of cancer.
Yeah.
And I think you suggested that could well be the case with prostate cancer. Yeah. How long do you think it will be before they find different types of prostate cancer and treat them differently? Or is that too much of a crystal ball question?
No, it's already here.
Is it?
It's already here, yeah. I mean, there's the fundamental difference between a Gleason pattern 3.
Yeah. We actually looked at slides in pathology the other week. Graham Staggs arranged that, so a number of the chaps looked at their own pathology slides.
Who was the pathologist who came?
It was up in the sand.
Oh,
Suzanne Danieletto.
Oh yes, she's a really nice lady.
Extremely
and there's another lady,
nice.
Monica, who's up there, who's fantastic. Monica Peduto. Let me just show you that picture again. There he is. So we know that these are two different animals. This Gleason pattern 3, individual glands, versus the branching pattern 4. It's these ones that can metastasize. It's these ones that can cause death. Most unheard of with 6. So we've already got that distinction. And to try and find the molecular differences between this is really, really a point of investigation. I spent 4 years doing it, I couldn't find it. Yeah.
Any more questions? Surely there must be some.
Are there circumstances where it may be difficult to implant the seeds into the prostate? In my circumstances, I've been told that it would be perhaps difficult.
It's a terrific question. I mean, it's of course one for the radiotherapists, but as someone who's done a bit of brachy, I can show you that. Let's go back to that picture of the guy with his legs up. Here. So what you've got in front is the pubic bone. So if your prostate is sitting up behind that pubic bone, how do you get that needle angled up? A few tricks. Yeah. If it's right on the rectum, how do you get it into that posterior part? Those are the kind of issues. A very big prostate is going to be very hard to cover with brachytherapy. And we used to talk about shrinkage with the hormones, but we now have a very valid option in external beam radiotherapy with the modern targeted systems, the IMRT, Rapidarc, whatever you want to call it. So it's not as a higher pressure anymore to have brachytherapy in someone we wanted very high doses of radiotherapy in, because we've got options.
Can I ask another one? I guarantee this will be my last one. I visit chaps in hospital, and certainly I must say that your patients think you're also a good guy as well as a good surgeon. So. But a number of men, their PSA rises after surgery. Is there some time limit or a suggested time, in your opinion, when they should have radiation? Should it be fairly soon after the surgery, or should they wait a significant amount of time?
So look, the first thing with radiotherapy after surgery, it can be in 2 settings. One is the adjuvant, where it's given as a planned part of the treatment because the pathological factors are negative, as in the patient may have, or unfavorable, as the patient may have a very high Gleason score, may have extensive disease outside of the prostate, disease into the seminal vesicles, or indeed a positive margin tumor at the edge of the specimen. So for those patients, there is this grand argument about adjuvant, that's a planned part of treatment, or salvage, which is if and when their PSA rises. And that argument is still ongoing. There's a lot of evidence that adjuvant is better. It makes sense when there's still fewer cells to mop up, But the radiotherapy in the post surgical setting comes with side effects. Number one, it fixes the continence where it is at the time that you have the radiotherapy. That's why you can't have it straight after. So if you're still having continence issues at 6 weeks, many men are, right? Continence improves, they say, out to 12 months. Mostly by 6 months, most guys are where they're going to be. There's some slight improvements after that. If you're still having trouble at 6 weeks, yeah, you've got an excellent chance of being great in the next few weeks to months, right? But if you have the radiotherapy, you'll be fixed at that point. That's the issue. And of course, radiotherapy does decrease the potency rates, even if you've had wonderful nerve-sparing surgery. So that's the argument against adjuvant therapy, and just have it in the salvage setting. In the salvage setting, the number of the PSA is what we argue about. Whether it be 0.5 or 1 depends on the institution. But certainly 1 is the upper limit. Dave?
Yeah, just one more.
No, go for it.
What about adjuvant hormone therapy? I've been reading Snuffy Myers, as probably a few people have. He seems to think it's the bee's knees, to go hormone therapy as an adjuvant to either radical or to radiotherapy.
So for radiotherapy, the data is pretty good that it decreases recurrence rates, etc., improves long-term survival. In surgery, it's not. So certainly surgery, where what we call neoadjuvant, you have it before your surgery, has been shown to decrease margin rates. That means you get less positive margins, but it doesn't translate into long-term disease-free recurrence rates. Interesting. In surgery, the adjuvant hormone therapy hasn't been shown to be useful. In radiotherapy, it is.
So is there a case that everyone doing radiotherapy should have adjuvant hormone?
The side effects. The side effects.
Terrible, I heard.
Are quite, it's significant, the side effects. And so all of the radiotherapists are trying hard to reduce the number of patients that do need to have hormone therapy. And so there are many studies that have gone on and are going on looking at which groups can avoid hormone therapy.
Okay, do we have any more? I think that's about it. You must have answered all the questions, Kris. That was an outstanding presentation and done in a very easy to understand style, which all us laypersons appreciate. I think it's answered a lot of questions for us, and I think we always learn something new from these sessions. So thank you very, very much for coming along this evening.
Thank you very much, Kris.